We are now moving into the targeted era in bladder cancer. And in fact, we're all talking about checkpoints, but when we start looking at checkpoint inhibition therapy, we're really not seeing more than a 25% response rate with single agents. So let's go on to our slides. Okay, so it's new targets for the treatment of urothelial carcinoma. 72-year-old male has metastatic urothelial carcinoma. He has progressive disease in the nodes after cisplatin-based therapy. He comes to see you to discuss his next treatment options. He requested that his tissue be stained for PD-L1 to help decide whether he should be treated with atezolizumab or go on a clinical trial. You tell him that one, only high expressors of PD-L1 in the tumor cells respond to atezolizumab. The duration of response is dependent upon PD-L1 staining. Patients with low levels of PD-L1 expression in the tumor-infiltrating immune cells can respond to therapy. And then finally, PD-L1 expression can help to distinguish between selecting a PD-1 or a PD-L1 inhibitor. So the answer is 3. Patients with low levels of PD-L1 can respond just as well as the high levels. Okay. Is PD-L1 expression a useful marker of response to checkpoint inhibitors, yes or no? My answer is it depends upon which assay you use and which treatment you use, but in general, I would say no. Since median progression-free survival is not improved in patients treated with checkpoint inhibition therapy, what's the best endpoint? Objective response rate, overall survival, 1-year survival, or 2-year survival? Yeah, my answer would be overall survival. I agree with that. So these are my disclosures. And as we mentioned earlier, immune therapy is active in a quarter of patients who are with metastatic urothelial carcinoma. We often see resistance, although I think the durability of response is probably the best with these treatments that we've seen with any agent to date. And there are a significant percentage of patients who are not fit enough to receive cisplatin-based therapy, so again, we're looking for other targets. Right now, we don't have any FDA-approved precision agent for bladder cancer, but we hope to see that in the near future. As we saw from Dan's talk, urothelial carcinoma is molecularly heterogeneous. There are multiple pathways that can be altered, but there's not one specific gene pathway like we see with CML in his last example. That's the best one to target. So unselected trials in the past have caused us problems. We see agents that may have more activity if we select out for different individual markers. So it's unlikely that I think these small studies are going to show positive results unless we enrich our patients for particular markers. So we know that there are multiple kinase pathways that are expressed in urothelial carcinoma, namely the PI3 kinase or mTOR pathway. We also see the FGFR3 pathway. Retinoblastoma gene is deleted, P53 is mutated. FGF is also mutated, same thing with EGF. About 20% of specimens will express HER2/neu. So again, we have a variety of different areas that we can pursue. And again, if these are low-level expressions of particular markers, we have to enrich, and we may not see any particular results. So this again is what I was saying before, RAS-RAF kinase pathway, P53. All of these can be targeted. Unfortunately, even though P53 is expressed or mutations are seen in a large portion of bladder cancers, we do not have a specific agent. This is not a druggable target at this particular point. So the actual mutation itself is not targetable. So I'm going to focus first on the mTOR PI3 kinase pathway. The TORC complex is important on the left for cytoskeletal organization. The mTORC pathway, which goes through the 4A-F3A and the transcription complex, is responsible for cell growth and tumorigenesis. And there are, again, as we see here, several different pathways that we can affect the conversion of AKT to the mTOR pathway. And again, TSC1 and TSC2 mutations are also involved in this particular pathway. So you can knock those out and then cause unopposed cell proliferation and growth. Everolimus is known to affect the TORC complex, and as we know, that's approved for metastatic renal cell carcinoma. There have been studies in bladder cancer, but again, they've not been enriched to the level that we'd like to. So we do know that there are TSC1 mutations in transitional cell carcinoma. It occurs in about 8 to 10% of specimens that have been examined. And the really important case, I think, that really got us to start thinking about this issue of molecularly targeted personalized medicine in urothelial carcinoma was a patient who was treated on an everolimus combined with pazopanib trial. And this patient had whole genome sequencing. This patient had a really dramatic response to this combination. And it was found that this patient had a TSC1 mutation, and that's what was the explanation for this patient's dramatic response. And this patient had a complete response that lasted 14 months, and there were activating mutations of mTOR that were seen as well. So not all size fits one. We have to be sure that we have the right population that we're studying. So at Yale, we're currently looking at a new compound. This is actually being done through the phase 2 cooperative group through the NCI. Joseph Kim, my junior attending, is actually running this trial. And what we're looking at is an ATP competitive inhibitor of mTOR kinase that will basically go after the TORC1, TORC2 complex. And this actually shows inhibition of TORC1, TORC2 at very, very, very low levels. And this potentially has greater clinical activity to those drugs that are out there in the community like everolimus or temsirolimus. So we're actually going to be doing TSC1 and TSC2 mutation sequencing on these patients. I'm going to select 25 patients for this particular study and see if enriching these patients will lead to a better response rate or reasonable response rate with this particular TSC1, TSC2 inhibitor. So this is a targeted therapy trial that is selecting patients based upon TSC1 and TSC2. The epidermal growth factor receptor family is expressed in probably about 70% of urothelial carcinoma specimens. The difference between EGF and lung cancer and bladder cancer is you don't see mutations to the same level that you do in lung cancer. It's a very, very rare event. And why is that important? Because those will predispose you to responses to some of the tyrosine kinase inhibitors that are very, very active in lung cancer. So we're really not absolutely sure of the exact role of EGF, whether it's a differentiation factor or it's a proliferation factor. And in fact, it may be dependent upon the molecular phenotype of the tumor that's examined. But Maha Hussein looked at trastuzumab, which is Herceptin. It's a HER2 new inhibitor in patients who had any form of HER2 new expression of bladder cancer. This could have been through serum. This could have been through tissue. This could have been through any primary DNA analysis. And she treated these patients with a triplet combination of paclitaxel, carboplatin, and gemcitabine, along with trastuzumab. And as I mentioned before, any method was used. Half of the patients had at least one method. Several of the other patients had, 2.8% had all three criteria. And when you look at those patients who had HER2 new expression, they tended to have a poorer prognosis, more number of metastases, and also more visceral sites. Response rates did not seem to be particularly different than what you saw with patients who were treated with that triplet regimen alone without the trastuzumab and were not selected. But if you look at the data carefully, these patients again seem to have more aggressive disease, and perhaps that's the reason why the events that were seen with this particular trial were somewhat worse. The survival was 14.1 months, a little bit worse than what you expect with chemotherapy, but again, it may be a patient selection. This drug has never been evaluated properly in a randomized phase 3 trial, again, from we see the 3+ patients, small numbers hard to determine, anywhere between 15 and 18 months. So I think it was an exploratory trial, but it wasn't necessarily indicative of where we should go with it. Same thing with the RISA, which is also an EGFR antagonist. We looked at this data in the Southwest Oncology Group, found only one response out of 30 patients. And again, we didn't select, but we could not, this was before the era of looking for mutations. And larger trials have found that there are no mutations in bladder cancer with EGFR. Tom Powles has looked at lapatinib, which is another HER2 new tyrosine kinase inhibitor, compared that to placebo in patients who had responded to chemotherapy. This was a maintenance trial. And this trial basically showed no difference in progression-free survival when patients received lapatinib or placebo after responding to chemotherapy. And when you look at this in terms of all patients, you can superimpose the survival curves. But even for the HER2 positives, we don't really see the difference. So this therapy or axis may or may not be active. We may not have the right drugs. Dan mentioned before that FGFR3 is expressed in urothelial carcinoma. It does seem to be more strongly expressed in non-muscle invasive disease than muscle invasive disease, but nonetheless, it is a therapeutic target that can be exploited. There are specific FGFR3 inhibitors that are now in clinical trials, and these are showing response rates of about 20 to 30% in selected patients. So there are activating mutations, and there's also upregulation seen of the particular receptor. Now, there are trials that are combining some of these targeted agents along with immune therapy. The Biscay trial is looking at basically 3 different inhibitors. One's a PARP inhibitor, Liperza. The second is an FGFR3 inhibitor. And the third is a WEE1 inhibitor, which is basically going after retinoblastoma. And this study is still ongoing, and we don't have any results at this particular point. Yale, we've been focusing on the VEGFR2 axis. As we know, there are several members of the VEGF family. There are several different drugs that are used and are FDA approved which target VEGF. Bevacizumab approved for lung cancers, predominantly targeting VEGFR1. Ramucirumab predominantly targets VEGFR2. And these have different effects on both lymphangiogenosis as well as angiogenesis in patients with urothelial cancer as well as other tumors. In the laboratory, it's been shown that antibodies to VEGFR2 combined with docetaxel chemotherapy can be chemosensitizing, and also the VEGFR1 pathway may inhibit metastatic disease, and again, also does have an interaction with chemotherapy as well. And this is just an IHC chart looking at the different expressions of VEGF in human tissue specimens. As we can see on the lower right, urothelial carcinoma has a high level of expression of VEGFR2. Now, angiogenesis inhibition therapy has been a bit disappointing in urothelial carcinoma. In the past with phase 2 trials, there's really been nothing that stood out as being particularly active. And of course, we have toxicity, particularly hypertension, that are seen with these particular agents. As we start looking at some of the combinations, we start seeing maybe a trend, and at Yale we did lead a phase 2 trial of docetaxel plus or minus ramucirumab, and we saw about a doubling of the progression-free survival. That's the line from the bottom, the second line from the bottom, and this led to a larger phase 3 trial that evaluated this. There is still one phase 3 trial that is still outstanding as far as any data is concerned, and this is the one that's being performed in the intergroup mechanism, GemCis plus bevacizumab compared to GemCis alone. It's still not mature, and hopefully we'll see something coming out this year on this study. But we went after the second line group because of our phase 2 experience, and we presented this data. This was published in The Lancet back last September. It was presented at the ESMO meeting, where we looked at the range trial, which compared ram docetaxel to docetaxel. These are patients who had prior chemotherapy, one prior chemotherapy for metastatic disease. Also, they had to have failed that, but they could have had checkpoint inhibition therapy. And in fact, 10% of our patients on this study did receive prior checkpoint therapy. Other key inclusion criteria were ECOG performance status of 0 or 1. We stratified this based upon geography. About 10% of our patients did have prior checkpoints. So this again was designed before the checkpoint era really was unleashed. Very similar baseline demographics from both arms. This is a heavily pretreated group, or at least a poor prognosis group of patients. When we start looking at the Belmont criteria, all patients, I think at least 50% of patients had 2 or more poor prognostic features. So our primary endpoint was progression-free survival. This was both by investigator assessment as well as by an independent review. Actually, the data from the independent review looked better than the investigator assessment, but there was about a 25% reduction in the risk of progression, which was significant in favor of ram docetaxel. The survival data is not mature yet. I hope that we'll have an answer at some point this year as to whether there is an improvement in overall survival. That's going to be the key. But these were co-primary endpoints, and I think the FDA, depending upon how close the survival data is, I don't want to speculate, but they may still accept it even though the survival data may not be significant. As we see, really nothing that stands out from the forest plots as far as any different subgroups are concerned, but there was about a doubling of the objective response rate in favor of ram-docetaxel, 24.5% versus 14%. Strangely, there was less toxicity in the combination arm, and this was actually somewhat surprising. In fact, we saw less anemia in the combination arm than we did in the single-agent docetaxel arm. So we've concluded that there was an improvement in progression-free survival, improvement in objective response rate, and we just have to wait until we see the data from the survival. We've actually gone forward with ramucirumab in this combination, in combination therapy. We've combined it with Pembro. This was a phase 1 trial that we presented at ASCO GU this year. It's currently being written up for publication, but nonetheless, a little bit disappointing in the responses, but a very, very small trial just designed to look at toxicity to see whether we can combine the two. And the lung cancer data actually looks very, very good, but there are probably more patients on that. Finally, the area that I think I'm the most excited about are these targeted ADCs, or antibody drug complexes. So enfortumab vedotin is a complex of a monoclonal antibody that's linked to MMAE, which is methylmeristatin, which is an antitubulin agent. This enters the cancer cell via the nectin receptor. Nectin is expressed in about 90% of urothelial carcinoma specimens. It's then cleaved, and the MMAE is released. It has an antitubulin effect. You get about 1,000-fold higher of a dose intracellular than you would if you gave this intravenously. In fact, you really can't tolerate this drug intravenously well. And then it causes cell death and apoptosis. So this was a phase 1 trial. We presented this data at ASCO last year. We're going to present an update at ASCO GU in a week. And we took patients, standard dose escalation, started at 0.5 mg per kg, eventually round up at 1.25 milligrams per kilogram, and then we did an expansion dose at that particular level. Nectin-4, as I mentioned before, is expressed largely in urothelial carcinoma. In fact, we initially had nectin staining as a prerequisite for going on this trial. We dropped that because, as I said before, 92% had nectin expression. This is our disposition of the patients with metastatic urothelial carcinoma. As of that analysis, we still had about a quarter of patients on treatment, and 37 had disease progression. The median age of these patients was 67, predominantly male, predominantly bladder as their primary site, but we had actually a fairly large number of patients with visceral disease, and about a quarter of patients had liver metastases. So fairly well tolerated. Neutropenia was seen. We also saw an increased risk of urinary tract infections. That necessarily was probably more due to the anatomical site of these tumors. We did see diarrhea. One of the expected toxicities, which was keratitis, we didn't see. And patients who developed keratitis with these types of agents generally require steroid eye drops. But we didn't see that at all with this particular complex. And these are just some of the other side effects: urinary tract infection, I mentioned before, hyponatremia, hypophosphatemia. So this is our waterfall plot, and as we see here, we saw responses at all dose levels. Again, this is going to be updated in 2 weeks. And at the different dose levels, we had an objective response rate of 50% at 0.5 mg per kg, and 30%, again, complete responses were seen at the 1.4 milligram per kg dose. So again, an active compound, and the question, of course, is does this make a difference in terms of whether these patients had prior therapy or not? So the 1.25 mg per kg is on the lower portion, 47% response rate in that group, 44% for all doses. When we look at prior taxane treatment, it's about the same, and then liver metastases, it's 50%. So this is an area where we really don't have a great deal of activity of checkpoint inhibition therapy. We're going to update that data at ASCO GU, and I can't disclose that at this particular point. But we also saw about the same response rate in patients who had prior checkpoint therapy, about 50%. So it's an exciting drug, and I think that it certainly could be a third-line agent after checkpoint therapy or after Ramdosi. But I think that, again, we have a lot of different ways that we can improve this disease, which we didn't have before. So we're looking at multiple targets in urothelial carcinoma. These include EGF, AKT, and FGFR. Angiogenesis therapy combined with docetaxel improves progression-free survival in a phase 3 trial. And I think, again, one of the more exciting areas are these targeted monoclonal antibodies. And we'll see more information. There are phase 3 trials ongoing.